everyone. From wherever you're joining at whatever time of day you're joining, it's really nice to be here. My name is Kevin McAvey. I'm a managing director at AcademyHealth. Health data is my life, and it's so wonderful, and it's such an honor to be able to, on behalf of the Robert Wood Johnson Foundation and AcademyHealth, have conversations about the pretty incredible Health Data for Action program, talking with grantees who have received grants from the Health Data for Action program over the course of the past 4, 5, 7 years, and talking about the impact that the program had in facilitating their work, the impact their work has had on the field, and a model for how many organizations can really work to use to identify the data they need to inform their policy, program, business decisions, and ultimately make an impact on our broader healthcare system. Data-based evidence is a powerful tool for helping researchers, community advocates, policymakers, and others uncover health challenges, better target limited resources, and measure progress towards ensuring that every American has the opportunity to live healthy lives. Yet for too long, many researchers have had a limited access to comprehensive and rich data about how our healthcare system is performing, a cornerstone of producing timely and objective research. The Health Data for Action program, our Robert Wood Johnson Foundation signature research program managed by AcademyHealth, has aimed to reduce the barriers often faced in accessing rich data by serving as a conduit between data owners and interested researchers. The program launched in 2017 and will wind down in 2026, delivering tremendous and novel research to the field and sharing with every researcher, policymaker, and data scientist a replicable model for how existing data assets can be used to create actionable insights about our healthcare system. Today, I have the pleasure of speaking with Dr. Carl Streed about his work exploring cardiovascular health disparities among sexual and gender minorities using EHR data. Dr. Streed is an associate professor at the Boston University School of Medicine. After attending medical school and residency in internal medicine at Johns Hopkins University, he completed a fellowship in general internal medicine at Mass Brigham and Women's. To achieve equity in healthcare access, health, and community well-being, Dr. Streed actively incorporates the principles of diversity, equity, inclusion, and accessibility into his work as a clinician investigator. His clinical training, advocacy, and research initiatives are nationally known and recognized. He has chaired the American Medical Association Advisory Committee on LGBTQ issues, served on the board of GLMA, Health Professionals Advancing LGBTQ Equality, and currently serves as the president of the U.S. Professional Association for Transgender Health. He is the research lead for the Gender Care Center at Boston Medical Center, where he collaborates with researchers, clinicians, and the community to assess and address the health and well-being of transgender and gender diverse populations. Dr. Streed, it's such a wonderful privilege to have you on today. Thank you for the work that you do.
Thanks for having me. Great to be here and talk about this.
Yeah, of course. And so whenever we talk about complex issues, which many of our data projects explore, I always like to go back to the people. Would you mind just bringing me back to why you pursued this project and how it goes to actually impact folks who are struggling with health challenges in the real world?
I don't know if we can go that far back in terms of my experience in healthcare as an undergrad, but that's where a lot of this originates from, is the experience of sexual and gender minority people accessing healthcare, their experience in society, and how that really affects their mental health, their coping behaviors, and their physical health. That leads to a number of conditions and the disparities we know that exist, particularly around cardiovascular health. I'm a primary care doctor. I see everyone, and naturally have a particular focus around the health and well-being of sexual and gender minority populations. So it's only natural that I'm focusing on a condition that affects so many people, for which we know, particularly trans communities, suffer significant disparities compared to their straight cisgender peers.
Why?
we're still trying to understand the why of that, and that's the
Yeah.
purpose of this study. And
Yeah.
there is a broader theory around health disparities experienced by minoritized and marginalized populations called minority stress theory. We believe that how people are treated unique to their identity affects their health, both at the individual as well as the population level. So we've done there's a significant body of research around this topic with regards to the experience of racial and ethnic marginalized populations. For example, the Jackson Heart Study finds that even in young African American Black youth, that their recalled experience of discrimination is actually tied to them having higher blood pressure at even younger ages. So we've seen this play out in other marginalized populations. Only recently are we starting to try and characterize this in sexual and gender minority populations.
Yeah, and so can you kind of break down and really kind of help me understand, like when we talk about sexual and gender minority populations, like who does that comprise? And then have we seen any like initial kind of guiding studies that have start to show like the disparities that these populations might face?
So there's so much we could cover. The when I say sexual and gender minority populations, I'm using the NIH's Sexual and Gender Minority Research Office definition, which really tries to encompass as many broad categories that we contemporarily understand: lesbian, gay, bisexual, trans, queer, but it also makes a point not to neglect additional identities. For example, the experience of indigenous populations with regards to sexual identity and gender identity, often encompassed as the term called two-spirit. But there's also the idea around differences in sex development or variations in sex characteristics, sometimes labeled as intersex. The definition of sexual and gender minority is really meant to be broad and really try and encompass non-binary concepts around sex, sexual identity, and gender. So I often use that when I'm talking about research topics and populations. Yeah. Naturally, I use the terms my patients use. If they tell me they're a lesbian cisgender woman, that's the term I use to talk about them and their experience. But broadly as a population, we talk about sexual and gender minority populations and subsets of those populations. In terms of the body of research that really gets at the experience of minority stress for sexual and gender minority populations, we have examples of essentially discrimination at young ages. There's work done by Dr. Caitlin Ryan out of the San Francisco State University called the Family Acceptance Project that measured levels of acceptance or rejection of family members towards their LGBTQ youth. And what they found was that higher levels of rejection in the home were tied to, down the road, youth essentially having higher likelihood of suicidal behavior or ideation, higher levels of anxiety and depression, higher likelihood of actually engaging in behavior that puts them at risk for HIV or substance use. But then when we see families that are more accepting, that are trying to understand their youth, provide support for them, those youth are actually able to move from a survival mindset, which is like day by day, just trying to get by, to a thriving mindset where they're really thinking about their future and can imagine themselves like, what do they want to be when they grow up? Those are like probably some key examples of what's happening at the youth level. But then when we look at adults, we have a unique set of situations in the US, given our patchwork of laws, that back in the 2000s, for example, when Massachusetts, the state where I'm living and practicing, when Massachusetts passed same-sex marriage, there was existing clinical data before and after that policy change that using research methods demonstrated that gay and bi men had lower levels of blood pressure issues and lower levels of need for treatment for blood pressure. This is another example of where a policy level factor could be affecting population health. Naturally, it's also been tied to anxiety and depression, but this is probably one of the earlier studies that really linked it to physiologic changes for people.
That's so interesting, and I mean, but yet it seems familiar, right? I mean, like if we and our listeners like really believe that we're a product of our experiences, and folks like depending upon who they are experience life in different ways, that could ultimately have different impacts on their health, which we need to acknowledge and then seek to address. Is that right?
That is absolutely the way we look at it.
Yeah.
I think the important thing is to recognize that people are treated differently based on their identity and how society values that identity or devalues that identity. And all of those experiences that are specific to that, whether it's at the individual level, family, and so on and so forth, all the way up to policies, those are all intervenable points that we as clinicians and policy experts can really try and develop interventions that improve individual and population health. It is true that everybody experiences unique stresses, but it's not the case that everybody is targeted for their identity.
Yeah, it's so powerful. And like, do any stories from your clinical practice really stand out to you that illustrates the importance of being able to, within this broader context of serving population health, really both respecting, identifying, and supporting individuals who are going through these unique, very personal experiences?
I think there's something to be said for when my patients come to me saying they feel isolated, when they don't feel like they can't turn to their family for a variety of reasons, more often than not related to them being rejected or kicked out and so forth. It's then my job to try and find community supports and connections for them. And that when they come back, having been successfully connected to some sort of community support, they are more at ease. Their mental health is generally a little bit better. Our measures of anxiety and depression are a little bit improved. And then that can feed into a number of factors, particularly as a primary care doctor, again, around cardiovascular health. It could lead to lower blood pressure. It could lead to fewer issues with regards to substance use or tobacco use, which is a coping mechanism. I've seen this most often when it comes to issues around isolation. I've also seen it when it comes to issues about hypervigilance, always being on guard, particularly when it comes to seeking healthcare. Healthcare has a history of not doing well for broader sexual and gender minority populations. I mean, we still have recent data, for example, from KFF, from the Kaiser Family Foundation, that shows that broadly LGBTQ people experience higher levels of rejection in healthcare than straight and cisgender peers.
I feel like when we're thinking about population health, we're always thinking about really making sure our population writ large is experiencing health improvement, and also targeting those populations that are high cost, that are high utilizers, that have specific needs and conditions. And this does seem to kind of play into this overall population health paradigm. I mean, do you see addressing health disparities as contributing to improving overall population health?
I mean, it's such a leading question. Like, yes,
I specialize in those.
I have to believe that. But there's data to support this. So I think to your point around, if we look at this from an economics perspective, people who have issues have fear and valid fear of healthcare, delay seeking care when they need it. They are not able to, and again, as a primary care doctor, it really pains me to know that somebody's not able to access care, and I can't begin to identify things before they become a problem. I can't treat your pre-diabetes, and then when you come see me, you have diabetes, or you're in diabetic ketoacidosis and need to be in the ICU. That is both a personal significant harm due to fear of the healthcare system for valid reason, but also a huge economic cost to the healthcare system when it costs much less for me to treat or prevent diabetes than it does to actually treat somebody in a critical situation requiring ICU level care. It's the same thing with regards to broader cardiovascular health in terms of trying to prevent a heart attack rather than treating an advanced heart attack with us needing to essentially do open heart surgery. But it's similar across other conditions. Cancer is another prime example that is often, in a lot of cases, preventable or at least detectable at earlier stages when it's more easily managed. But we definitely know that there are higher levels of more advanced cancers in a variety of populations, particularly in lesbian and cisgender women. We see that to be an issue. We also are beginning to think this may be an issue in gay and bi men. So again, it comes down to, if we can't create a system that is more welcoming, it's going to harm people. We know it's harming people, and it will also cost the system overall much more to take care of folks.
And I think that's, again, like a really strong argument for why we want to make sure, even just from a systems perspective, we are really addressing the needs of these populations.
Absolutely.
So,
I want to, apologize to interrupt. I want to point out, like, there's actually very specific recent research utilizing even just measures of anti-discriminatory policies within healthcare systems, looking at the Human Rights Campaign's Health Equality Index, and tying that to measures of patient satisfaction and the likelihood of a patient recommending a family member or friend. In healthcare systems that have higher scores on the Health Equality Index, patients are much more likely to recommend that healthcare system. But what's interesting here is that research was not able to disaggregate based on sexual or gender identity. It was all patients. So this potentially means that straight cisgender people benefit when we address these policies and improve healthcare overall.
That's really interesting. I mean, and I like it's also I feel like we're at like almost a nascent stage at the development of this kind of foundation of literature, which your research through the Health Data for Action program is only going to be building upon. Is that right?
Exactly.
So, but I want to talk about your your research in this project, and then I want to come to like the broader, bigger kind of picture question of the role of this research within a different national environment than when maybe the research was first proposed. But
Yes.
first, let's talk about the project. Can you describe your research project a little bit? What you were like, how you were approaching it, and who like what you were hoping to, what new information you were hoping to get out of it.
Yeah, so I will say this is kind of the culmination of many years of work by myself and others in the field for the past few decades. To be able to look at populations, we need to be able to identify them. And for a very long time, we did not have sexual orientation or gender identity data, often abbreviated as SOGI data. We have not often had this at large enough numbers and broad enough populations to really look at differences experienced by subsets of people. Particularly, sometimes we always have to group. We talk about sexual and gender minority populations. We always have to look at them all together compared to straight cisgender peers. And while that's good, it doesn't really allow us to get more granular. It doesn't allow us to identify specific issues that may be affecting subsets of the broader population. Since the requirement of SOGI data collection within electronic health records, we've seen larger numbers available to actually look at population research at the real world level. We're not talking about randomized controlled trials. We're not talking about clinical trials. We're actually talking about real data about real people in the community where they seek care. And my research is utilizing a large electronic health record system across a number of large health systems across the U.S. to really drill down and understand what are the unique factors affecting the cardiovascular health of lesbian cisgender women, bi queer people, transgender people of all sexualities. What's going on for their unique cardiovascular needs, their risk profile, and potentially who's doing well and why. And so my research is utilizing a large data set to really drill down into a more granular picture of cardiovascular health for these populations. That's only possible thanks to the existence of policies that have really pushed from recommendation to requirement of SOGI data collection in electronic health records.
And this is only in the past few years, right?
Correct. It's really only been, I'm forgetting the exact year. I want to say meaningful use requirements went into effect, I want to say after 2013. So we only have a couple of years of data where we have a broad enough sample. And this is the similar case we've had from other surveillance systems in terms of just a few years of data recently. For example, the CDC's behavioral risk factor surveillance system has only really been collecting gender identity data at a national level since about 2014, 2015.
But it's starting to give you a big enough sample size and also kind of like longitudinal time series to like look at outcomes, right?
Exactly.
Yeah.
And also, and very objective clinical measures. Not only do I have somebody, like they have a diagnosis of hypertension, I know what their blood pressure is. I know what degree of blood pressure do they have. I know their A1Cs for their diabetes. Are they not only experiencing diabetes, but are they being controlled? Are they getting their A1C below the goal of 7% and so forth? These are the things we can look at with a large enough sample of real world clinical data.
Yeah, and I'm assuming that's why you also wanted to target and try to find clinical data that could be used here to get those A1C measures, to get those detailed diagnoses. Is that right?
Exactly. There are not a lot of data sets like this in the U.S.
So what tips, just actually when we're thinking about like clinical data sets writ large, where do you, what like tips would you have for other researchers thinking about whether, how, and where to find clinical data sets?
I think the first thing you need to really address is like, what's the research question? What data do I truly need? And what degree of ideally self-reported data is available out there? There's a number of algorithms that can be used. There's natural language processing and so forth. But for me, nothing really beats the gold standard of patients telling us who they are and really trying to find those data sets out there.
If you're a researcher and you're really trying to look at the experience of patient populations, when would you go to a clinical data set and when would you go to a claims and encounter data set? I mean, obviously claims and encounter data sets I think are more widely available, but they might be more limited in what they're able to share.
Exactly. I mean, there again, it comes down to the research question. What are you trying to do? What's the question you're trying to answer? That really defines what data source you may go for. And I've used claims data sets for a variety of reasons, often, as you mentioned, because they are more available. But again, they don't give us that granular data. Our diagnosis codes, our ICD-10s, our CPTs looking at procedures, get at what happened and what the clinician recorded, but it doesn't get at everything that went on in the encounter. It doesn't give me the blood pressure. It does not give me people's lab values. It doesn't really give me much more other than like, yes, they got diagnosed with something. Yes, I see they had a heart attack. Yes, I see they had a procedure around that, but I'm not going to really know which artery was affected. I'm not going to know more granular details. Exactly. I'm not going to know what's their actual cholesterol level to even run my own calculations. For example, if I want to look at a population level, how well certain prediction tools operate, a claims data set can't do that, because I need the very specific clinical data to be able to predict who has a higher likelihood of having a heart attack or stroke. I need to know their cholesterol. I need to know their blood pressure values at the time of those measurements. I need all of that can really only be found in electronic health records.
Yeah.
So that's what we miss in claims data.
Yeah. I mean, I couldn't agree more. And I think that there's also this balance of wanting a certain level of clinical data granularity while making sure that the patient level information is blinded and we're maintaining patient privacy and confidentiality. Like when you're engaging in a research project like this, like how do you strike that balance, and how do you make sure that we're not actually looking at individuals, we're looking at these very targeted subsets of populations?
I think it's always critical to try and aggregate data as best you can, and don't ask for data variables you don't know what you're going to do with. Too often do I see people asking like, oh, we want to get down to zip code. I'm just like, well, if you're not doing neighborhood level analyses, why do you need a zip code? Why do you need to know specifically where somebody's geolocated and so forth? It really comes down to, and this is also from my own experience having co-chaired an IRB, I'm like, why do you need that data variable to answer your question? That needs to be very clear and very explicit. And you need to, if you truly do need it and you've provided justification, what are all the steps you're going to protect that data? At the end of the day, our patients typically understand that we utilize their data to improve their individual health as well as the population health. And that requires us being upfront with them when they seek care, but also on the back end, guaranteeing a number of steps to protect their data. As a researcher, I really do my best to use the least amount of data to answer the question as best I can. And that really means being very upfront and honest and saying like, okay, I'm not going to be hunting for 20 different things. A priori, what are my hypotheses? What's the data needed to answer those questions?
Science.
Yeah, exactly. It's the standard scientific method I learned in grade school.
Yeah. And I think we could all use a refresher every now and again.
Exactly.
But so answering the question. So talk to me about your research project. Where are you? How close are you to answering some of those questions?
Oh, this is the reality of working with large data sets. It takes time to just even obtain the data. It gets down to the larger point of like, again, all these steps we are taking to be very deliberate about what information do we need from our data vendor. How are we going to operationalize those unique characteristics? Because we don't need them to give us necessarily all of the raw categories. For example, of like all of the ICD-10 codes for a particular condition can be broken down to multiple decimal points. Did they have a heart attack or not? That's what we're looking at. Did they have a stroke? Yes, it is an interesting question of like, okay, was it a middle cerebral artery? Was it a vestibular artery? Interesting, but not part of our research question. So we're just looking, did they have a stroke? So these are all the steps we are taking right now on the back end to make sure our data set is as usable as possible and as manageable while getting at specific granular data and respecting patient privacy and confidentiality. And then, of course, there's just the reality of we are fortunate to have quite a large data set, so we are making sure our system can accept that and run that and do it well. And then, of course, there's always the legal side. We are making sure that our lawyers and our vendors' lawyers are all in agreement about who's responsible for what, how we can do this as effectively and safely as possible, and how are we going to manage the results afterwards.
It's critically important due diligence, as you were talking about that balance of privacy and confidentiality, while in pursuit of like scientific findings that can ultimately go to help people and
Exactly.
help and improve their health.
Exactly.
So, what are those hypotheses that you're specifically testing in this project?
There, there are a number of hypotheses, and I will say even a large part of my research, I always joke, a lot of it is like water is wet studies. Like those of us in the space know it,
Yeah.
and we see it every day with our patients and the communities in which we serve and live. But sometimes we need hard numbers to really explain that. So going in, looking at, for example, broadly, again, looking at this group together, that sexual and gender minority populations have worse cardiovascular risk factors leading to worse mortality and morbidity. There's no big surprise there. We've seen those kind of results in other population sets, just not necessarily large clinical data sets like this. So that's first what we're looking at. But then we want to get into the particular nitty gritty. What is going on for specific subsets? And we hypothesize based on minority stress theory that populations that are often less connected to community are probably going to fare worse across a number of risk factors and outcomes. We believe, for example, that bisexual cisgender folks are going to fare worse than their lesbian and gay counterparts because of experiences of minority stress, not only from the larger straight cisgender society, but also experiences of isolation from lesbian and gay communities, which has often been an issue over the past few decades. Similarly, we'll be able to look at the same question in trans populations. What's going on for non-binary folks compared to their trans men and trans women binary peers? Similar issues around this notion that society doesn't really like people who don't fit into discrete boxes. And this is one of those situations where we've seen this a little bit in some population data. For example, in the behavioral risk factor surveillance system, we had found that gender non-conforming people, as the category they provide, actually had worse self-reported health compared to transgender women and transgender men, let alone cisgender peers. So we believe there's some signal there. So we want to really get at how can we look at these essentially non-binary categories around sexual identity and gender identity.
Yeah.
Further, we do want to look at who's doing well. We don't have a good picture, but we want to try and figure out how can we best define people who have quote unquote ideal cardiovascular health according to the American Heart Association. And that means like no hypertension, no diabetes, they have no sleep disorders, and so on and so forth. What is unique about them compared to people who maybe have less ideal cardiovascular health? And we're trying to tease that apart. And again, that's something we can only do when we have more granular clinical data.
I mean, all of this, just to me, it's an exercise in observing the world as it is, increasingly capturing and reflecting that world in data, and really thinking about how we can learn from those observed experiences to improve patient health.
Yep.
Is that fair? And that seems like a good thing to me, generally. Yep. Like, let's just, hopefully we can all like agree that that's like a pretty good thing, right?
Typically. I haven't touched on it because I know we might talk about it a little bit later, but with the level of data we have, and the years of data that we have, we're hoping to be able to explore what are the effects of state level policies. Can we do, for example, differences in differences analyses where like as soon as a policy goes into effect, what's happening to the population in terms of their general health?
Yeah.
Similar work has been done looking at the experience of LGBTQ youth with regards to suicidality. We see that when states enact discriminatory policies, suicide rates go up, and it's been particularly tied to those policies. We believe similar things will happen around broadly cardiovascular health, or at least the risk factors of cardiovascular health.
And we have seen like long-standing historical state-level variation in policies that are advanced to protect populations like these, or to address like disparities that we know in practice probably exist, right?
Exactly, and it's we are at a point where there probably isn't a more significant divide between states that provide protection and ensure equitable access to care and states that do not. And right now, those differences are, unfortunately, it's sometimes a cold research way of saying it. It is a natural experiment. The current policy landscape is creating a scenario where we are going to see the harmful effects of a variety of policies.
Yeah, because not only in the past 6 months have we seen, do we have this current state of play with differences in states, but our federal administration has changed, as well as the perspectives of that federal administration and what it's willing to fund and what it's willing to kind of support. How is the federal environment, because which has changed significantly from when this project started, changed this work in any way, or has it changed the work in going on in the field more broadly?
The current federal environment has made the work all the more urgent. And research, as much as we like, just is not a fast-moving thing. And again, we're seeing a situation where policies are being enacted. There's federal actions that are going to lead to harm long-term that we might not be able to immediately detect for the next few months or over years. But that also means there's current actions to prevent us from even being able to do that. There are efforts to remove SOGI data from national surveillance systems. There are efforts to change regulations around the inclusion of SOGI data in electronic health records. There is essentially a coordinated federal attempt to erase LGBTQ populations, SGM populations, from the record so that we can't highlight what's going on. I think there's something to be noted with regards to the current federal environment in how it not only affects data, but it's also going to affect the next generation of scientists and clinicians who do this work. It's very much targeting the ability for early career folks to continue this work and to really make a name and really obtain the methods and expertise to really define and address the experiences of SGM populations. And it's also, particularly my experience as a clinician, it's making it harder for folks to receive clinical care and training experience specific to broader LGBTQ populations, particularly transgender populations. And what I worry about us seeing is that we're going to see fewer clinicians capable of providing care or being savvy enough to do the research. And we're probably going to see particular areas in the nation where there are going to be fewer clinicians. Clinicians will essentially vote with their feet and go where they feel they can practice to the full extent of their licensure and training. And so there may be states where people, overall, everybody will suffer as a result of these policies targeting broadly SGM populations.
That's really helpful. And I hope on a personal note that we can always maintain and support and advance a healthcare system that allows individuals to feel respected and seen. And by being seen, we're really kind of thinking about how to address their unique circumstances and needs to support better health. So this project, do you have are we thinking 2026 for some early findings and to have you back on something?
I'm hoping we will have some preliminary data by the end of this calendar year. I would anticipate there probably being more public stuff by the beginning of 2026. But yes, we will. We are moving in earnest at this point.
Well, we're really looking forward to that. But before we wrap up, what lessons learned? I mean, I'm sure even at this point in the project, there might be other kind of tips you would share with researchers who are starting to formulate their research questions, starting to think about what data resources they should leverage. What have you learned so far, and what tips would you have for others who are just engaging in that process writ large, and then particularly engaging in that process in this area of investigation?
Overall, I think it's always important to be working with people who are familiar with the data you're seeking, whether it's the data source in particular, but at minimum understand the data itself. So for example, there have been a number of conversations where my colleagues, PhD level trained and folks and so forth, are not the ones providing the clinical care. So they may not have the experience around why is one code being used over another? What specific information do you need? And this is where my clinical training actually helps inform how we're going to do the research. So again, recognizing working with people who are close to the data, who are close to how the data gets entered and interpreted and so forth is critical. This is what I do, for example, when I'm working on outcomes specific to mental health. I like to work with mental health clinicians who have more training than I do in this area to make sure we're looking at everything correctly. Next, work with a data specialist. Work with people who really know how to generate the data source, really get things appropriate in the forms you need, and really know how to run the methods. I was fortunate to get a master's in public health. I have just enough stats knowledge to be dangerous, but I really am not. I'm really not as versed as I would like to be at some point. But right now, that's why I always make sure my team includes people who are smarter than myself. I never want to be the smartest person on the team. I always want to be the one who is working with smarter people. So I think that's really important. And then lastly, I would do my best to insulate your understanding of the value of the work from the outside world, particularly now. I think you really need to not think about how is this work of value to people in power at all times. You do want to try and get the work disseminated in a way that's understandable for people in power, but you don't need them to give you validation for doing the work. And I think that's always important.
Dr. Streed, I feel like conversations like these are never more important than they are now, and always bringing it back to the work that we are collectively doing. So often just goes back to seek to improve the health of individuals who need help. And I think through this conversation and your work, it has a really important role in doing that. And I really appreciate you and the work that you're doing, and for coming on and chatting for a little bit.
I greatly appreciate it. Thanks for the time.
No worries. So thank you to Dr. Streed. Thank you to the Robert Wood Johnson Foundation and Academy Health and the Health Data for Action program. If you haven't checked out our other interviews, check them out on our website.